A popular misconception is that when a couple is unable to conceive or get a child for whatever reason, then the problem is most probably the woman. In actual sense, issues of infertility are shared equally between man and woman, and in 30% of the cases, the cause is unknown. Infertility has driven wedges in relationships. Marriages have ended up in divorce just because a couple could not conceive. On this episode of Health Digest, we shine our spotlight on infertility, particularly looking at the options that are available in the country, from intrauterine insemination for the women who qualify for this, and even in vitro fertilization, giving you an exclusive look to what happens behind the scenes in the laboratory. I'm Dr. Masi Korir.
We meet a 34-year-old whom we shall call Nelly. Nelly is visiting this facility in a bid to find answers regarding her difficulties in conceiving for the last 5 years.
Niko na 35 years. Nimekuwa nikipitia challenge ya kupata mtoto. Kutoka 2014 ndio nilirealize after niliolewa nikakaa kwa ndoa for 2 years bila kupata mtoto.
Nelly suffered a miscarriage earlier on in her marriage but has been unable to conceive again after that.
Nilikaa sana bila kuconceive, and then there's a time niliconceive alafu ikatoka kwa sababu ya uvimbe ambao nilikuwa nayo kwa tumbo. So that time nikaenda nikatolewa, and then from there sijai conceive tena.
As a couple, they agreed to have doctors run tests on her first before her spouse can consider doing the same.
Nilifikiria kuna shinda wakati nilijua niko na uvimbe, ndio nilifanya juhudi nikaenda nikatolewa. Kutoka hapo sasa kufikiria kama niko na shinda ingine.
She is afraid that being unable to conceive may eventually break down her marriage.
Nimekuwa tu nikihesabu siku zangu ndio nione siku zangu zenye niko fertile. That is what I've been trying to do. Kutumia the fertile days. Naogopa niende nipatikane siwezi kupata mtoto. Hiyo ndio wasiwasi yangu kubwa. Juu sasa nipatikane siwezi conceive. If I cannot conceive kabisa, sijui kama ndoa yangu inaweza simama tena.
While Nelly has sleepless nights from being unable to conceive, on the flip side, we have women who are at a proper childbearing age but are unwilling to start at the moment. Most of them can opt to freeze their eggs as they pursue other interests like career development, education, or even waiting for the right partner. Is it something you would consider?
Kiwe mayai kama umerifikisha menopause.
Kabla ufikishe?
Kabla. Juu sasa zingine labda hutaki kuzaa wakati huo. Sasa wakati itafika ndio unaweza sasa kutumika.
I think it's a brilliant idea because after all maybe these days we don't want to give birth at this age. Maybe if you give birth it's just one baby or two, but later you may consider having more kids. So I think it's a bright idea.
Would you do it yourself if you are able to?
Definitely, I would.
To me it's a no, because when I want to give birth, I think I'll do it at early age, because when I'm 40, life begins at 40, I should be out doing other thing, investing, blah, blah, blah. To me, it's a no.
It should be natural, and the natural provision has it, because we have, the conjugal interest and service must take place. There must be a product of the exercise. So ili aliweka huko ikae huko, hii tuko nayo tuachirie ikutanie pale inastari kutania, tutoe mtoto. Anaweza kupanga mpango alitafuta mtu mwingine, so cannot be trusted.
A woman in society often has to pursue career interests in a similar environment as men, while at the same time worrying about a ticking biological clock. Many a woman who reached the age of 30 would often be asked when she plans to beat the biological clock by bearing children. This might no longer have to be the case, with science and medicine giving women an alternative to literally freeze time by freezing one's precious eggs. Egg freezing can be done up to the point when the lady is ready to conceive, even if it is several years later. At that point, the eggs undergo in vitro fertilization and transferred to the uterus as embryos. If considering the option, it is important to note that there is no guarantee of success, and natural fertility still carries a higher pregnancy rate for women who are otherwise fertile. Though many may not agree with it, it has been termed as a way of having your cake and eating it.
It's kind of an insurance for your own eggs, which you can use later. Otherwise, we see a lot of couples who come after the age of 40 and they don't have their eggs. Then they have to resort to donor eggs, because if they are not making their own eggs and still they want a child, they have to take donor eggs. With the oocyte freezing, they can have their own biological child. Most of the girls, in fact, don't know about it. Nowadays, we have oocyte freezing program. A lot of girls postpone marriage either because of education or career, or sometimes we see a couple got married, then they got divorced, then they get remarried. So by the time they reach that age and they are not able to find another suitable partner, so we do offer oocyte freezing, and we tell the young girls that if they are postponing marriage or pregnancy for any reason, then they must freeze their eggs, because it's a biological clock which is ticking. And after the age of 35, it's mainly the number of eggs as well as the quality of eggs which decreases, and a time comes when she will not be left with any eggs. So if she goes under stimulation, we can take out her eggs and we can freeze with us. Say if we are freezing at the age of 33 or 34 and she decides to get married when she is 38 or 39, then those eggs are, the eggs aging we have stopped at that age. So it can give her a better result rather than using the eggs at an older age. And we can keep them frozen for as long as she wants. All over the world, we see that the rate of infertility amongst the couples, married couples or living together trying for pregnancy, it's almost 20 to 25%. And those are the couples who need help in some sort of assistance in which there can be problems either with the female or with the male. And it's a myth that the infertility is only because of the female. We see almost 40% of the cases are because of the male factors. So whenever a couple comes, then we look at the female and we look at the male problems. We try to find out where the problem is, and then we offer them the treatments which can vary from starting the tablets for egg formation, or depending upon the semen count, depending upon the duration of infertility, we can offer them IUI, which is intrauterine insemination, or if the IUI doesn't work, then we move on to IVF or ICSI. When the couple comes to us, we try to investigate them. We do a set of hormone investigations on the female, and the ultrasound, the basic ultrasound, which we have very good 3D advanced ultrasound machine, and I do the ultrasounds myself to look at the uterus and the ovaries, where is the problem. And based on these tests, we find out what is the reason for the infertility. And for the males, we do the semen analysis. So first of all is the name of the patient, the date she came to us, her address, the email ID, the mobile number, if anything needs to be conveyed, and how she has been referred to our clinic. The wife's age, as I told you, it's very, very important. Then the husband's age, the occupation. So again, it can also tell us about the lot of factors which can be the cause of infertility. Then we ask them about their sexual history. Sometimes, we see the husband or the wife, they are traveling and they are not together for a long time. So that can again lead to infertility. Then for how long they have been trying for pregnancy. The menstrual history of the female, when did she start with the periods, how her periods are, whether they are regular or not. Then we have the obstetric history, meaning if she has ever got pregnant or she has got any miscarriages or any live babies and any cesareans or any other surgery which she has undergone. Then we look into the past medical history, the history of tuberculosis, which can be one of the reasons for infertility in the female especially. Any history of thyroid disorders, hypertension, diabetes, or any other problems if she has had in the past. So we keep a record of that. Any past surgeries if a lady has undergone, because we see a lot of patients who have cysts, who have endometriosis, or who have undergone the tubal surgeries for opening the tubes. So we all keep a record of that. Then in the family history, it's very important to look at the closed family members, especially the siblings or the mother and father, if anybody has suffered from tuberculosis, hypertension, diabetes, because it usually runs in the families. And we keep a record of the height, weight, and the BMI of the patient. This helps us in assessing the BMI, which is very important. If the BMI is more, if somebody is obese, we ask them to reduce weight, as well as for deciding the dose of the injections also. Then coming to the investigation sheet, we do the routine investigations for the wife, and we do the viral screening of both the couples. It's mandatory, like the hepatitis B, C, HIV. All these routine tests are done. For a female, we do the hormone profile, the basic hormone profile, which gives us a clue about the number of eggs that are available, or if there is any problem anywhere, we can correct that. Then another important test is the ovarian reserve testing, which is done by AMH, the anti-Mullerian hormone testing, which I would suggest every girl should get it done once she is at the age of 30. So it will give us a clue about the ovarian reserve that is left in her ovaries, and with the age we will see normally it keeps on decreasing. So there are cutoff values, 1 to 4 is the normal, and anywhere we see that the AMH is going down, we ask them that they should hurry up, or if they are not married, they should go for the oocyte freezing. Then there is a test for the tubes, which is known as HSG, the hysterosalpingogram, which tells us about whether the tubes are open or not. We do SSG here, that is sonosalpingography, which we can do on the ultrasound. Then a routine ultrasound we always prefer to do so that we can look at the uterus and the ovaries. If the couple has any genetic issues or if they have ended up with recurrent miscarriages, then we advise for the karyotyping of husband and wife, which tells us about any chromosomal abnormalities. Then some patients might require laparoscopy and hysteroscopy, especially the failed cases.
So this when you're looking, surgical procedure, you're looking into abdomen and into the uterus.
Yeah. and especially if they have undergone laparoscopy, hysteroscopy, we make a note of this, that this was the problem. Or if they have not undergone and they have had failures, then we advise them to go for laparoscopy, or if there is any cyst, if there is endometriosis, we need to correct it. And similarly in the uterus, if we suspect there is a septum, there is a polyp, or there are fibroids, then we can remove them surgically before offering them IVF, because otherwise the IVF would also fail. So these are the tests that are done routinely. And then there are special investigations in patients who have had recurrent failures, like protein C, protein S, thrombophilia. These are only reserved for specific patients, not for all the patients. Then coming to the husband analysis. In this, the husband semen analysis is the most important thing, and date-wise we look at the semen analysis that they have undergone, if there is any improvement or it has worsened. So we look at the previous reports, and we also advise them to have one semen analysis done at our place. And if we suspect any infection, we do the culture also. And if it is an azoospermia patient, then we advise them to go for the hormone test. And as I told you, the viral screening is mandatory for both husband and wife, and we make a note of it. Normally we try to do a natural cycle monitoring once to see if the lady is making any eggs or not. How is her endometrium, how is the uterus, and we can keep a record in this. And in the end we have the patient diagnosis, what is the reason, like if she has say tubal factor, the tubes are blocked, so we mark this. So we can we know that we are dealing with this, and we make a note of the treatment plan accordingly. Whether I am planning to do 2 IUI cycles or straight away. If it's a severe male factor, then straight away I will write down IVF ICSI or IUI, or she needs laparoscopy. So that is how we keep a record of the treatment plan. Then this is the investigation sheet which we do for the female as well as the male. For the female we do the hormone test. Certain tests are done on the day 2 of cycle, and the most important, as I told you, are the AMH and the ultrasound. So we tell them if they cannot afford the other tests, these are the 2 important tests that they are mandatory, as well as the viral screening. Similarly for the male, we do the viral screening and a semen analysis. So once we have the results, we can reach a diagnosis that here is the problem and we need to focus here. And based on that, we offer them the either some couples conceive only with the timed intercourse, meaning we give them the medicines, or we just track the natural follicle. And when the egg is ready, we ask them to have timed intercourse, because the egg can get fertilized only up to 24 hours. So if most of the couples, they don't even know that which is the best time to have pregnancy. So even if we advise them to have timed intercourse, 20% of them would conceive with that. Then based on the semen reports, if the semen count is say between 10 to 15 million, then we offer them insemination, IUI, which is known as commonly. So in that basically we give some medicines and injections to a lady, so that instead of 1 egg she makes 2, 3 or 4 eggs. And we track those eggs on the ultrasound again. When the eggs are ready, we take the husband's semen sample, we wash it in the lab, in which the dead sperms and the abnormal sperms are separated, and the best motile sperms, they are injected into the uterus. So the traveling time from the vagina to the uterus is decreased, and we time it in such a way that the sperms can go and fertilize the egg. So that is insemination. But all over the world, the IUI results are maximum 20%. In spite of having good egg, putting in the best sperms, only 20% chances are that they would get pregnant. IUI is a little cheaper option. So the couples who can conceive with IUI, we first offer them that. And maximum, I would say, if you go by the evidence, you can offer them even 6 cycles, but it becomes a little frustrating for the patient. So I would offer 2 to 3 cycles of IUI. If they don't conceive in that, then we ask them to move on to IVF.
Still to come on Health Digest.
The embryologist will pick up one sperm and he will inject one sperm into one egg. So we make sure that the egg is fertilized outside.